Okay, at-risk newborn. I want you to get a piece of paper. Everybody needs a piece of paper. And I want you, as we go through this scenario, to write down your responses without we don't put anything in the chat yet. If you're with someone else, don't talk amongst yourselves yet. I want you to write down your responses. And then we're going to come back and put things in the chat and work on work through it as a group. So you report to work in your L&D unit and you're assigned to the triage area. You currently have one patient. Here's your report. Cece came in about 2 hours ago complaining of cramping. She's 19 years old, 32 and 5/7 weeks gestation, G1, P0, no complications. The OB office says she's been in several times for minor complaints. I've had her on the monitor since she got here, and I don't see any contractions. Fetal heart rate's in the 150s, moderate variability. She's got AC cells. I don't see any D cells. Her UA did show a UTI, so maybe that's why she's cramping. She's ready to go home as soon as her antibiotic script comes through. She's getting dressed. All you have to do is discharge her, give her that prescription. Okay, so that's your report. How many of you took notes in report? Yay, good. You've got that from clinical. All right, now do not answer this in chat yet. I want you to write this down on your paper. First of all, what is your immediate impression of what's going on with CC? Okay, just write that down. And then I want you to write down, what do you do to prepare before you go to see CC? In clinical, you're beginning to learn about time management and doing more than one thing when you go to the patient's room, and the fact that if it feels like there's not a lot to do right now, you should still try to get ahead because other patients can come in at any time. So keeping in mind that you can get another patient at any time in this triage area, you need to be efficient. What do you do before you go to that patient's room? Start making your list. So while you're gathering everything up to go to Cece's room, you hear screaming, help, help, help. So you run down to the patient's room and you see Cece in the bathroom on the toilet, hovering over the toilet with feet and legs hanging. She's yelling, help. What do you do now? I want you to write that down. Help arrives and the baby's delivered. One colleague starts an IV on Cece and prepares Pitocin. Another is assisting the provider with delivery of the placenta and monitoring the fundus and bleeding. You are waiting with the newborn for the special care nursery team to arrive. What is your first action? Write down the first thing you do. What is your second action? And what is your third action? All right, so I want to go back to the top, and now, because you've written down your individual answers, I want to see some things in the chat. So what was your initial impression based on report of what's going on with this patient? Be honest, no hindsight. Okay, not what you think at the end. What did you think at the beginning? When you got reporting, you had not seen her yet. What did you think? Because quite a few of you are saying precipitous labor, but okay, Brandon still thought it's preterm labor. Can you let me know what made you think you should still be thinking about preterm labor for that patient. Good, Cassie. Okay, so what did the way the nurse presented that report affect your thought process about the patient, about what was going on? Definitely, because then the way it's presented, it sounds like this patient probably is okay. She has a UTI, give her some antibiotics, send her home. Okay, Cassie says no, she couldn't believe she had not been checked. So what error do you think was made at the beginning of this scenario? What error do you think was made at the beginning of this scenario? Okay, good. So when we have a patient who has frequent complaints, and maybe seems very anxious, it's easy for us to assume that this time is just like the other times. Okay, so that's one. The patient had a lot of previous complaints that turned out to be minor, and so the nurse kind of assumed it was going to be like that. And also the nurse did not pick up those contractions. How many of you, I know that at Idaho we haven't had a lot of chances to do labor and delivery. So how many of you have gotten a chance to see a preterm labor patient at another facility? That may be why you were thinking that, Cassie. So when the patient is in preterm labor, if you put the toco up at the top of the fundus, you might not pick up contractions. You have to move the toco around to different locations, and frequently in preterm labor, if it's at the top, the contraction is not pushing that button. Okay, good, Cassie. So before you say there's no contractions based on external monitoring, I really want to see that toco being placed in several different places, and the nurse trying to palpate when at the time the patient is feeling some cramps. So that's one. We probably needed to verify better that the patient was not having contractions. The other is if a patient is having symptoms consistent with preterm labor, then someone needs to do an exam. And I worked at a facility that was a teaching facility, and there were always residents in-house. And so for preterm, nurses did not examine those patients because we didn't want to trigger further contractions or maybe cause an infection in a preterm patient. But the residents would come do a speculum exam because there's lower risk of infection with that, and see if there was any cervical change. In a small facility where you don't have a doctor that's going to come in and do that check, you really have to evaluate the safety of sending a patient home, or the risk of sending a patient home without an exam who has some symptoms of preterm labor. Okay, so the next is, what are all the things when you still were thinking this patient has a UTI, she's getting ready to go home, what things are you gathering to go into that room? And some of you probably are gathering some items to do an exam because you wanted an exam on her before you sent her home. And I saw 2 or 3 people that suggested that. So I want you to look at your list. What things are you getting together, and what things are you doing to prepare before you go into that room in the first place? Okay, you're planning, you've got some information about UTI, so you can do some teaching. Sterile gloves to do an exam. Are there any lab results? Okay, teaching. Review the chart and labs before you go in. Oh, is there a previa? Okay. So what things do you want to teach this patient? Remember, right now we're getting ready to send her home thinking she's got a UTI. What do we want to teach her? Okay, front to back, hygiene care. What else? What else? Okay, false and true labor signs, increased water, kid counts, hydration. So anytime we send a patient home after UTI, we need to teach about hydration and hygiene, right? Anytime we send a patient home from labor and delivery that's pregnant, we need to teach them what should tell them to come back. So what are those danger signs? Good. Call if somebody doesn't feel right. She knows her body best. That's a good one. But things of what's the difference between false and true labor? So what if you had gone in to teach that patient the difference between true labor and false labor, and she starts telling you, okay, but this is what's happening with me. You're going to check her, right? You want to follow up on those cues. The beginning part of this story is about making assumptions and about bias. Okay. Bias isn't always against a particular person or against a characteristic. There's also something called not confirmation bias. It's something when you have made a decision or made a judgment about what's wrong or about what the situation is, and you don't allow for any other possible options. You don't think about other things that might be. So this might be a patient comes in with chest pain. They are not having a heart attack, as evidenced by labs, EKG and stuff. And so the provider decides they have maybe muscle pain. And then if when they're talking about other symptoms, the fact that they have muscle pain is, or the assumption they have muscle pain is affecting all the other decisions. So all the other symptoms get ignored. Okay. So there's a type of bias where what we have decided is the case, we tend to just ignore everything that doesn't support that. Okay. So we've got to make sure that even though we think we know what's going on, we're being open to other things. Okay, so the situation suddenly changes, patient screaming, you run down the hall, go in the room, the patient's hovering over the toilet because while she was changing clothes, she decided she needed to go to the bathroom, and their feet and legs. So this is a breech preterm baby. Okay, what is your immediate worry? Big immediate concern, breech preterm baby. You start thinking about all the things that could happen and what am I going to do about it? Chris Underwood, yay, good job. Okay, so those other things do matter. Lung function, we've got a preemie. Hemorrhage, because we weren't prepared for this delivery. One big one at the moment of that delivery is the preemie's head is bigger in relation to the body. And so there's a bigger risk of the aftercoming head getting stuck. Think about how far the cervix needs to dilate to deliver a baby at 32 weeks. Okay, the cervix doesn't even have to dilate all the way for the body to come out, but then the cervix isn't dilated, so the baby may get stuck. Okay, so what do you do in that situation? You run in the room by yourself and there's feet and legs hanging out of your patient. What is your first response? Oh, they're also on the toilet. Okay, we want to assure mom and baby safety. How do we do that? What are the specific actions? Okay. It is too late for monitoring. We aren't monitoring anything. That baby has to get out. So we stay with the patient. Don't let the baby hit the floor of the toilet. Try to get her into a safer position. Some people said get her in bed. Some people said get her on the floor, but get her into a safer position. We could actually just have her sit on the toilet with her like at the edge of the toilet so that we can help get the baby out at that point. NICU team, yes, I want somebody else there to take care of that baby. We're going to have a 32-weeker out in a few minutes, we hope. Okay, so we call for help. We stay with them. We want to get that patient positioned for as safely as we can so that the mom doesn't fall if the baby doesn't deliver and hit the floor. Okay. Someone said grab blankets. Good job, Montana. And then we want a NICU team on the way. We also want a provider on the way. All right, so help arrives, the baby delivers. We have one colleague starting an IV on CC. Remember, she was getting discharged. She doesn't even have an IV. And that person is preparing some Pitocin to prevent hemorrhage, okay? We have another person assisting. The provider shows up. Must have been in-house because they got there that quick. And we have another person helping with delivery of the placenta and making sure that the fundus is firming up after the placenta. You get the baby. Okay. Special care nursery is not there. You have a baby. You have the warmer's there, but it's cold. What is your first action? Okay. What is your second action? And then what is your third action? All right, so we're going to go and look at the very top of the NRP algorithm. Because we're not going to do the whole thing. Special care is going to get there in a minute. The very first thing we evaluate, it's not term gestation. The amniotic fluid was clear. Is the baby breathing or crying? So we want to know if that's happening. Do they have a good muscle tone? If all those are true, then it would be routine care, but we already know it's not term gestation. Okay. So the very first thing I want to do is look at that baby. I want to look, are they breathing and crying? Do they have muscle tone? Are they floppy? Okay. And then if we go to the no section, because it's not term gestation, it says provide warmth, position and clear airway, dry, stimulate, reposition. We've been trained from day one to do ABCs, ABCs, ABCs. But the very first thing we need to do is get that baby dried and in a warm place. So I want you to think really quickly, how can you get that baby warm? You really need the baby to be, this baby's going to need some help breathing. And it's going to be almost impossible to do that on the mom's abdomen. If this is a full-time baby, going skin to skin would be priority. But this is 32 weeks. They're probably going to need some help breathing. So if we don't have the option of skin to skin, what are you going to do to keep that baby warm? Okay, warm blankets. And you want to dry and then get a cap on. You want to dry them and you want to use warm blankets. So this was actually an actual scenario. And that's exactly what we did. We got a stack of warm blankets out of the blanket warmer and put one under the baby. We dried the baby, and then we had a warm blanket at the baby's head and over the baby's body. But those have to be in position so that we still have easy access to make sure that the baby is, to help the baby with breathing and things like that. And the provider arrived fairly quickly to begin the to do the other resuscitation things to handle the respiratory status. I'll tell you something else, that when that baby was first put on the warmer, the retractions were really severe. Okay, retractions were so hard that it looked like the sternum was touching the backbone. Within about 5 minutes, the retractions got a lot better. The baby was still flaring, still had some retractions, but it was better, and the baby's color was better. Why did that get better without any breathing assistance or oxygen? That it got better before we even got oxygen hooked up and on the baby. Why did it get better? Okay, we provided some warmth, so that decreased the amount of energy that had to go to maintaining temperature and gave the baby more energy and oxygen to focus on breathing and other vital functions. Okay, special care nursery arrives and takes over the care of the baby. The mother is given the opportunity to see the baby before he goes to special care nursery, and she goes to postpartum. You clean your triage area, set up for the next patient, work as a resource nurse for your colleagues until another patient comes in to triage. Now, in a small labor and delivery unit, they may have only 1 or 2 labor nurses, and they're going to do all the labor, all the admitted patients, and do all the triage. But in a large labor and delivery unit, 1 nurse may be assigned to just take all the patients that come in for triage that day. Okay. And assignments, you've probably seen this if you've had L&D clinicals yet. Assignments change through the day. You're usually not assigned to the same thing all day long. You may be assigned to your patient, somebody delivers, you get another patient, or you get assigned to go do triage, or you get assigned to do recovery on MAG patients. So assignments fluctuate a lot more on an L&D unit, more similar to what you might see in ER than med-surg. Okay, so the next thing I want to do is go through some of the effects of prematurity on body systems. So on this exam, there's a lot of questions about prematurity because it's the most common complication. There are questions about the other complications in the newborn. So you need to know all of them, but prematurity is the most complex one, and it's probably the most common. And so we're going to look at what prematurity looks like in a baby. So I want you to think for a minute before we go to those notes. I want you to write down again, just make a list of body systems. And then I want you to think about a baby that is born at, say, 30 weeks and what those body systems might look like. Okay. What do you think those body systems look like? So when you see this baby, put it on your paper first, and then we'll talk about it in the chat. Okay, just jot down what you think a baby looks like at that gestational age. Okay. Skipping past the infection stuff first. Let me go to preterm. Okay, general appearance. What does a preterm baby look like? And here's where I want you to put it in the chat. The things that you were jotting down. Okay, smaller, low birth weight. We're thinking about appearance, low birth weight, thinner skin. Okay, not a lot of brown fat, which we can't really see the brown fat externally, but what else do we not see? They also have fewer creases in the hands and the feet. What else? They may be cyanotic if they're not getting enough air. More lanugo, more vernix. I don't know about rupture. I'm sorry, I don't know about range of motion. They tend to actually be more flexible. Weak suckling and swallowing, which we'll get to that in a minute. Think about what they look like. Think about body proportions. Remember, growth is cephalocaudal, proximodistal. Okay, floppy ears, wrinkly, larger head in relation to the rest of the body. Also think about what happens in the last part of pregnancy. The last few weeks of pregnancy, they're adding fat, right? So less subcutaneous fat. Now, probably at 30 weeks, it's not going to be transparent, but when we're looking at those little tiny 23, 24 weekers, you can see through their skin. Okay. All right, so now I want you to think about neurologic differences. How is the neurologic system different? We're on neuro. So they may struggle with sucking and swallowing. Reflexes may not all be like we would expect. Okay, respiratory effort, higher risk of brain bleed. Why? Why do they have a higher risk of brain bleeds? Vessels are more fragile. Oh yeah, they may be an extension instead of flexion. So not only are their vessels more fragile, but so are their bones are, their joints are more flexible. The bones are a little bit, they're not as ossified. They're not completely ossified at birth anyway, but they're less so. Okay. They have softer skulls, so they may have more molding, especially since we're also not moving them around as much. All right, now I want you to think about the respiratory. And somebody said this about 3 times, but I want to know what specifically is less mature about the lungs. Okay, at 30 weeks, we're looking at surfactant. Probably have most of their alveoli. If we're looking at early preterms, they may have fewer alveoli and they're farther from the capillaries, but later on 30 weeks, we're probably getting close, but they aren't producing surfactant yet. So what happens because they don't have surfactant? Why do they struggle to breathe? The alveoli don't want to stay open because the surfactant is what breaks that surface tension and allows the alveoli to stay open. Okay. So when that baby is born, they may be breathing on their own and look like they're doing okay. Okay. 30 weeks, they're probably going to look like they're having a little trouble, but a little bit later than that, they may look like they're okay for a while. But they get tired. So why do they get tired? What's causing their gas exchange to not? It takes work. It's taking work. The first breath is a lot of effort for a baby, but once they've inflated some of their alveoli, then the next breath is easier and the next is a little easier. But the surfactant isn't there. And so that allows those alveoli to keep closing. Good, Cassie. So it takes as much work to keep reopening them over and over and over. So they get worn out. There's a lot more work of breathing, which means that they're using calories they can't afford and they're using oxygen they don't have. Also, they forget to breathe at times because the respiratory center in the brain. So that's a connection between the neuro and the respiratory. They forget to breathe because they're not supposed to be on the outside yet. Okay, cardiovascular. I want you to think about how prematurity affects the cardiovascular system and think somewhere around 30 weeks. Fragile vessels. So what if they still have shunts? They still have blood going from one side to the other because the pressure doesn't even out. So those openings still stay open. The ductus arteriosus and the foramen ovale. Okay. So when we talk about blood going from the right side to the left side of circulation, we call that a shunt. Or when we talk about blood going from the left side to the right side, okay, we talk about cardiovascular shunts. And I want you to learn to remember these: right to left shunt or left to right shunt. Okay, so which type of shunt is normal in utero? Right to left. They're going to have a right to left shunt in utero because the blood that would be going to the lungs is not. And why isn't it? Why doesn't that blood go through to the lungs? There's an opening between the atria and there's an opening between the pulmonary artery and the aorta. But why does blood go through those openings? Okay, the lungs are not inflated well. What else? What keeps the blood from going there? There's a higher pressure in the vessels going to the lungs because they're not inflated, but why else? What else keeps the pressure higher? Remember that the pulmonary vessels are constricted. The pulmonary vessels are tighter. So because the lungs are collapsed, they're not inflated, and the pulmonary vessels are tighter, there's a lot more pressure on that side, okay? So the blood goes from right to left. Now, at birth, when the baby takes a breath, it opens some of the alveoli, so that decreases the pressure a little bit, but it also increases the oxygen in the baby's bloodstream, and that increased oxygen causes relaxation of the vessels that go to the lungs. So that lowers the pressure on the right side, the cord's cut, that raises pressure on the left side, so now it equals out, right? So those openings can start to close. So I want you to think back to the things that can happen to a premature baby's respiratory system and how that might cause a persistent right to left shunt. What about the respiratory differences might cause a persistent right to left shunt? If they don't get that breath in, okay, they don't get that breath in, so the lungs don't inflate. Okay, what else? They don't have the vessel dilation, because if their oxygen level never goes up, those vessels don't dilate. The vessels stay constricted. So they'll maintain a right to left shunt. So that can happen sometimes. It's called persistent pulmonary hypertension. That doesn't happen to every premature baby. It's something that can happen. So what do you think happens if they do get that breath in and the vessels do open up? It evens out, right? Except that in preemies, their lungs are softer. And so it actually may go too far, and now the pressure is lower than it would be in the right side of circulation. So then what happens? A left to right shunt. Okay, you can end up with either a right to left or a left to right. And you need to understand that both are possible for a preemie. Okay, that's really important. Either way, if blood's going through those openings, they don't close when they're supposed to. All right. So GI tract. How does prematurity affect the GI tract? Sorry, I don't know what happened there. How does prematurity affect the gastrointestinal system? They have a smaller stomach, they can take less in, and they have absorption problems. They need more calories because everything takes more energy. They take more energy to breathe than a full-term baby. They take more energy to maintain their temperature, but also it takes energy to eat. Good, Allie. It takes energy to get the food in, and sometimes they burn more calories eating because they're not coordinated with sucking and swallowing yet. They burn more calories eating than they actually get from the food. Okay. Temperature regulation. How does prematurity affect temperature regulation? They don't have brown fat yet. They have thin skin. Okay. Why are they cold? They lose heat easily. What else? Takes energy to maintain temperature. Don't forget that subcutaneous fat. There you go. Subcutaneous fat is insulation. They actually metabolize brown fat to make heat. The subcutaneous fat is insulation that helps keep the energy in, keep the heat in. So they don't have that. They're losing heat more easily. They don't have what they need to make it. And maintaining temperature takes energy away from breathing. Okay. So they actually get hypoglycemic from trying to stay warm and breathe. Good, Crystal. They also can't vasoconstrict as well, which makes it even harder to maintain that temperature. All right. So liver. How does it affect the liver? How does prematurity affect the liver? Binding sites for what? So the immature liver has a harder time conjugating bilirubin. Good. And part of that is because the liver's immature. Part of that's also because we have a hard time getting food into them. And remember, they need to be fed to start having binding sites for that bilirubin. So delayed feeding contributes to this. So jaundice is more likely. We also need to treat it more aggressively because they cannot afford any energy dealing with that jaundice either. Metabolic. I want you to think about hypoglycemia and preemies. Why are preemies more prone to hypoglycemia? They have to work harder. They use more glucose, and it's harder to get food in them. They use a lot of their energy to breathe, to maintain temperature, to survive. And we have a harder time getting energy into them because they can't eat as effectively. All right, immune system. Yep, everything takes more oxygen and glucose, and they have decreased ability to get it in. And that is prematurity condensed. Okay, you need to know the specific things, but almost all of it comes back to everything takes more work, more oxygen, more glucose, and we have a hard time getting them in. So their immune system is immature. They're more likely, they have a harder time fighting infections. Even a newborn immune system is, but it's even less developed. What else? Infection takes energy from other things. Okay, if they have an infection, that takes energy away from breathing and staying warm and eating and digesting, all those things. Prevention is the most important because if they get an infection, it's hard to treat. Okay, fluid balance. How is fluid balance affected by prematurity? They don't concentrate urine as well. What else? Thin skin, they lose more. What else? It's hard to get it in. So fluid and electrolytes, we have a hard time getting enough fluid and electrolytes in them. It's easier for them to be dehydrated or overhydrated. They don't handle fluids as well either. So that's hard to get intake, but also their kidneys and heart cannot handle overload. Skin. We've talked about the skin changes and how they affect all of those other things. One thing to know about skin is they can absorb things more easily through the skin. Be really, really careful with skin products, especially anti-infective things. All right. I want you to pull out your cards or your list of, the plan was to give you index cards to write your 3 areas of need from your exams on. But if you have your 3 NCLEX areas that you struggle with the most on your previous exam, I want you to get those out. And I want to talk about preterm infants. So I want to talk about the ones that the groups had the lowest scores on or struggled with the most. One of those was basic care and comfort. So let's relate basic care and comfort to a preemie. What kind of things are in basic care and comfort? Things like hygiene, pain management. Oh, leave some vernix. Excellent. Scrubbing all the vernix off can affect the baby's microbiome. So think about safety things, because this baby where is that baby supposed to be at 30 weeks? It's supposed to be floating in water in the uterus. So our care and comfort should focus, a lot of that should be focused on trying to recreate that environment. So we want low stimulation. We're going to get to that one because one of our other areas was infection control and safety, Abigail. So focus on the environment for care and comfort. Think about lower lighting, the room temperature. Hydrotherapy might be used on older preemies, but not on itty bitties. Slow controlled movements, that's a good one that avoids startling. If we startle that baby, they're using up a lot of energy. Watch stimulation. Okay, so think about how basic care and comfort applies to that. Now, another one was safety and infection control. So think about how that applies. Hand washing. Where was the other one? Make sure that proper PPE is being used. Make sure we're not carrying infection from one to another. Tell them what we're going to do, just like we would with adult patients. And that goes with the basic care and comfort. But there's a lot of overlap between that and safety, because if we disrupt that baby's environment, we're using more of their resources. No sick people around. Good. What about, oh, no kissing, absolutely. Herpes is scary. So think about infection control. Think about avoiding injury. Okay, think about preventing injury. So if, sleeping in bed with the parents, especially preemies, same room but not same bed, handle easily and slowly, support the head, slow movements for those bitty preemies. All right. I also have a new-ish or a new acronym. I want you to write down, oh, don't sleep with siblings if multiples. Good. I saw that, Ms. Parker. I want you to write down latte, L-A-T-T-E. Excellent, Chris. And that's going to go under physiologic. Okay. So let's look, we're going to switch gears and we're actually going to move to a different complication. We've spent a whole lot of time on prematurity. We're going to move to some different complications. Latte is an acronym for the things to remember about a disease process. Okay. So if acronyms are your thing, this may be helpful. So the L stands for what would they look like? And we're going to talk about newborn sepsis. Okay. So write down latte, and the L is for what would that patient look like? So what would a baby with sepsis look like? Newborn sepsis. Okay, newborn sepsis. Frail is not specific enough. I want to know what I'm going to see. Besides a robust, full-size, full-term baby can have sepsis. So we're looking at, what does sepsis look like? Cyanosis or pallor, high respiratory rate. What else? What does shock look like? Temperature, good, Kirsty. Lethargic. They might be cranky and fussy. They might quit crying and be lethargic. Depends on how sick they are. Vomiting and diarrhea. Seizures, tachypnea, bradycardia, grunting. All right, we're going to go back. Abdominal distension. Why would they have abdominal distension? It's correct, but I want to go why. Even if the infection is not in the GI tract, why they might have abdominal distension? Why? Why would they bloat? What would decrease the motility, Chris? We're getting there. Energy. If they're fighting the infection, they don't have energy to digest, so it can affect their digestion. Okay, so that's what I want you to do with every one of these things. There's a list of the symptoms of sepsis, and I want you to go back and look at every one of them and why would they have that? Okay, why do they have a low body temp? Why don't they run fever? No energy to regulate. Why don't they run fever? Fever is an inflammatory response. It's an immune response, and we don't have it. Okay, as newborns. How many of you have taken care of adult patients with sepsis and been told by the nurses, cold sepsis is scarier than hot sepsis? Do you know what they mean by that? They explain what they mean by that. Okay. If your adult patient has cold sepsis, that means they have used up or they do not have any ability to fight the infection because they're not running fever, and fever is a part of that immune process. Okay. Newborns do not have that ability. So if they're not maintaining their temperature, or if they're septic, they're going to have a hard time maintaining their temperature. They cannot mount that response that would cause fever. Okay, so that's what the baby would look like. Now, what would you assess? You have a baby that is floppy and their temp keeps dropping, and when they try to eat, they throw up and they're lethargic. What do you assess? I want vital signs. What else do I want? Be specific about labs. What labs? I'm going to assess their glucose. Good, because if they're septic, their glucose may drop. Okay. CBC, are they likely to have an elevated white count? They may not. Cultures, we're going to try to figure out where the infection's coming from. What else are you going to assess? Because y'all are talking a lot about, we're talking about labs. You've talked about vital signs. So what else are we going to assess? Reflexes, yeah, because that could show decreased neurologic response. Bilirubin, what else? Okay. We're trying to find the cause. What are we going to do to find the cause? I want to assess them for any, like if there's any external site of infection, and I'm going to listen to their lungs and their bellies, but we're probably actually, their blood cultures is probably what they're going to really want to find out. But they're trying to find, they may do a urine culture to try to find out if it's in the urine. In the old days, they did spinal taps on a lot of them. Okay. All right. So we've done look, what do they look like? What assessments we would do? We also covered in that assessment what tests might be done. The first T is for test. What do they look like? What do we assess? What tests might be done? Now, what is the treatment for newborn sepsis? Antibiotics, and when do those antibiotics need to be started? Stat. Okay. So antibiotics need to be started quickly. We do not wait for cultures to come back to start them. Why? The infection will overwhelm that baby before we get cultures back. Okay, so besides antibiotics, what do we do? They might need fluids. What else? Supportive treatment. If they're having trouble with getting oxygenating, they may need O2. If they're having trouble maintaining glucose, they might need some D5. We want to help make them not have to work to regulate their body temperature. We want to decrease the amount of energy they have to use for other things. Good job. Okay, that's supportive treatment. Now, the last is what education should you provide? Hand hygiene and PPE. Okay, what else? Teach parents what it might look like if their baby gets that sick. Transmission-based precautions, depending on what that is. Okay, teach them about replacing equipment, and we need to be doing that as well. Okay, now I want all of you to choose one other topic. There's post-term, there's infant of a diabetic mother, there's substance use disorder. I want you to look through the lecture and choose one other complication. We've done infections and we've talked a lot about preterm. So let's see, we've got post-term infant. We have SGA and LGA. We have birth injuries like brachial plexus injuries and hypoxic brain injury. Someone could do some of the complications of prematurity, like neck. Someone could do drug-exposed infants, hemolytic disorders, infant of a diabetic mother, meconium aspiration syndrome. Okay, so I want you all, you don't have to call them. I want you to each pick one and do a latte on it, and then we're gonna come back in 10 minutes and have like one person do each different topic. Okay, so let's take about a 5-minute break and see if anybody's ready. Okay. So, do you think that that tool is helpful in breaking down disease processes? All right. I don't want you to use it as another memorization tool, okay? I want you to use it as a prompt, and for every one of those things, for everything that we're doing for the care of that child or that person, you can use this for any disease process. There's a why. So always ask the why. All right, the last thing that I want to do on your CJ Sims, there are 2 different babies that we can use, okay? So I want you to take a minute and go to CJ Sims. Oh, somebody did a hemolytic disorders one. This one's good. Yes. Good, Cassie. Okay, on CJ Sims, you're going to go to the maternal child unit. Do you remember how to get to CJ Sims? If you don't remember how to get to CJ Sims, you go to your NurseThink portal, learning.nursethink.com, go to CJ Sims. You're going to select the maternal child unit. And I want you to do Isabella and Daniel. And I want you to do those independently first, and then we'll go through them. Anybody having trouble finding CJ Sims? Okay. When you log into, don't go to the regular NurseThink page, go to learning.nursethink.com and log into your portal. Sorry. You're doing Isabella and Daniel. They're both infants in the maternal child unit. Okay. If you can't get in today because of internet, we're going to do these as a group in a minute. If you don't know how to get in, please get with your campus instructor. These are short little simulations that can be that are helpful with clinical judgment. So do Isabella and Daniel. It is not. When you go to the portal, don't go to the regular NurseThink page. Go to learning.nursethink.com. When you log in, you're going to have a NurseThink Complete RN, and you're going to have a button that says, or a big icon that says CJ Sims. Go to CJ Sims. Let me show you what it looks like. I'm already in the unit, so I'm going to back out. Okay. On your NurseThink portal, you're not going to Complete RN, you're going to CJ Sims. In CJ Sims, you select your unit, and you're going to do Isabella, and Daniel. All right, we're going to go ahead and start Isabella. I just looked at the time. And it only takes a few minutes to get through these, but we're going to get through at least one of them. Okay, so we're going to listen to the handoff. There's a way to get the transcript if you need to read it. Okay, I'm going to the transcript because you can't hear. So here is our transcript. I'm going to move my chat box so I can see it. This is the delivery of 37-year-old Susan Marinucci, a primapara with a history of chronic hypertension. Her fetus is 34 4/7 weeks gestation. Her pregnancy was uneventful, and a private healthcare provider managed her blood pressure well throughout the pregnancy. She is planning a vaginal delivery with an epidural. Her membranes ruptured and she came right in. She was 6 centimeters dilated when she got here, and they gave her a tocolytic, but they couldn't stop labor. Luckily, they were able to deliver 2 doses of betamethasone before delivery. There's a single fetus and the mother is Rh negative. The baby is crowning, so I don't think there's much time now. She's scheduled to deliver in her LDRP room unless there are complications. We moved the warming bed and neonatal supplies in there for you. Let us know if you need help. Okay. So that's our report. Let's go to the quiz. All right. It says, before answering this question, review the client's health information on the EHR. Review the following paragraph. Select to highlight the 3 areas that concern the nurse the most. Okay. So let's look at this. APGAR. A sec. At O250, breathing effort 0, heart rate 1, muscle tone 1, reflex irritability 1, color 0 for APGAR of 3. Are you able to see this screen pretty well? Okay. All right. So we've looked at this screen. Let's look at flow sheets. This is the newborn's vital signs. Let's look at other things. All right. So let's get to the question. What things do we want to highlight in this paragraph? Tell me what you want me to highlight. Hypertension. Okay, what else? Rh negative. 34 weeks. Okay, do we have anything else that we want to highlight? All right, let's go to the next question. We need to arrange these in the correct order. This is, we're going to initiate newborn resuscitation for this baby. If there's something you want to review from the chart, put it in the chat so that I can pull it up. So which one of these things should we do first for that baby? Okay. Dry, warm stem and open the airway. I saw somebody say CPR. Which one do we want to do? CPR, then open airway. All right. Let's do that. By CPR, you mean cardiac compressions? Airway first. We've got a debate going. I cannot see your votes, but I'm seeing more airway. So let's move up here. Dry, warm, stimulate, open the airway. Is that what you wanted to do? Okay, what do we do next? What's the next thing? If we're going to do this one first, what's next? CPR and then epi. All right. What about after that? IV fluids. Okay. Look at the entire order and tell me if there's anything you want to move. Okay, we want to move this oxygen up before epi. Is there anything else you want to move? Anything else? Going once. Move this up. How far up? Before CPR. So we're going to give that baby some help breathing before we start compressions, okay? Anything else before we move on? All right, I'm going to go to the next question. Okay, complete this sentence using the drop-down options provided. The infant's blood glucose is what? Well, we got to find it first. Where's the blood glucose? It's not on that. That's vital signs. Other. Okay. Let's go back to nursing. Let's go further down. Okay, here we go. We got more notes. We're looking for the, I'm scanning for the blood glucose. Capillary blood glucose 52. Okay. Which is that low, adequate, or high? A blood glucose of 52 is high. Is that what we're going with? Okay. Requires treatment with, what are we going to treat with? Okay, someone said a bolus. I've got lots of insulins and a bolus. Okay, but if you can only do one, okay. All right, let's go to the next question. We're going to submit and finish. And let's look. Three areas of concern. Okay, I think that's what we tried to highlight, and it says we highlighted. I may have moved our highlights. Prematurity with a history of chronic hypertension, yes. 34 weeks, yes. RH negative, yes. I think I might have accidentally moved your highlight there. So you got that one. Let's look at, this is the neonatal resuscitation. Okay, the first step is dry, warm, stimulate, ensure an airway. You did that. If these are not effective, heart rate does not increase then we do blow by oxygen. So blow by would have been above that. Then positive pressure ventilation, then cardiac compressions if the heart rate's less than 60 or less than 80 if it's not increasing. Then an umbilical line, epinephrine, IV fluid. So you had everything in order except this blow by oxygen should have been up here before we start ventilating. Okay, here's the one we really need to look at. Okay, blood glucose is low. Hold on a sec. Okay, blood glucose is low, requires treatment with feeding. Okay, so review normal blood glucose levels. Make sure you look at the difference between venous and capillary and the difference for a newborn versus an adult. Okay, so we're out of time. I want you to do the Daniel CJ Sim also, and make sure that you read the debriefing so you understand why the answers are correct or not. Now I'm going to stop this recording.